hyperoxalemia and hyperoxaluria. Excessive urinary oxalate concentration leads to formation of insoluble calcium oxalate that induces renal stone formation, crystalluria, nephrocalcinosis, and then evolution towards the end-stage renal disease. The renal failure is followed by bone complications, cardiac conduction failure, vascular pathologies, neuropathies, ocular and skin manifestations. Conventional dialysis is unsuitable for PH1 patients reaching end-stage renal disease because it cannot overcome the continuous overproduction of oxalate. Despite concern about the recurrence of oxalosis on the transplanted kidney, kidney-alone transplantation has been shown to provide better survival results than other available treatments. Identification and isolation of the causative liver enzyme in the 80s opened a new avenue of treatment. Hence, it has been shown that the simultaneous correction of the underlying metabolic defect and the renal failure by a combined liver-kidney transplantation offered excellent outcomes. However, controversy remains concerning transplantation strategies. Some centers still considering the kidney-alone transplantation as the first therapeutic option, while the combined implantation exposes to specific risks. The aim of our study was to evaluate the results of transplantation in France for the PH1 patients, depending on the type of the transplantation initially performed. That is to say, a kidney alone or a combined liver-kidney transplantation. Our secondary objective was to evaluate, to establish a national survey of current transplantation practices concerning this disease. Between May 1979 and June 2008, 78 transplantations were performed for 54 patients with PH1 in 10 French centers, which represents 75 renal grafts and 45 liver grafts. The results were analyzed depending on the type of the transplantation initially performed. That is to say, kidney-alone transplantation for 21 patients or combined liver-kidney transplantation for 33 patients. All patients had reached end-stage renal disease at the time of transplantation. Mean age of the first signs at the onset of end-stage renal disease and at the first transplantation was the same between the two groups. Also, there was no difference concerning the time spent in dialysis before the first transplantation and the presence of extrarenal symptoms. Death-censored renal graft survival was dramatically and significantly better for the combined liver-kidney transplantation group, reaching 87% at 10 years. Recurrence of oxalosis on the transplanted kidney occurred in 47% of the patients in the kidney-alone group versus 0% in the liver-kidney group. Also, chronic rejection was 19% in the kidney-alone group versus only 9% in the combined liver-kidney group. Age at transplantation, as well as the period of transplantation, that is to say before or after 1995, had no influence on these results. There was a small tendency to a better patient's overall survival in the combined liver-kidney group without statistical significance. In both groups, the time spent on dialysis did not impact the post-transplantation survival rate. In the kidney alone group, 71% of the patients required a kidney retransplantation, as compared to only 12% in the combined liver-kidney group. In the kidney alone group, 47 patients needed a liver transplantation in order to secondarily correct the underlying metabolic defect. In the liver-kidney group, only 6% of the patients needed a liver retransplantation due to an allograft failure. The retransplantation rate for a recurrence of oxalosis was 38% in the kidney alone group, as compared to 0% in the liver-kidney group. All these values were statistically significant. For each patient, the average total number of kidney transplantation was smaller in the combined liver-kidney group. It was 1.1 compared to 1.8. Here is my conclusion. This study analyzes for the first time in France the result of transplantation for PH1 patients reaching end-stage renal disease. It clearly showed a superiority of the combined liver-kidney transplantation over the kidney alone transplantation. Indeed, the combined approach provides better survival for the kidney graft, provides a lower risk of retransplantation. In addition, there was a little tendency to a better overall survival of patients without statistical significance. We therefore suggest that the combined liver-kidney transplantation should be the recommended option for PH1 patients reaching end-stage renal disease. Thank you very much.
Thank you. That seems very clear outcome of that study. In France, would it be